Welcome back. Today we're jumping into a topic that is, I guarantee you, going to show up on your rotations and, yep, on your oral board exams, pleural effusion. Nailing this is all about having a solid, systematic approach, and that's exactly what we're going to build right now. Okay, let's get into it.
So here's our game plan. We'll kick things off with a basic definition, then we'll get to the huge question, transudate versus exudate. After that, we'll walk through the actual workup. We're going to master Light's criteria, talk about management, and then finish up with those key takeaways you've just got to have memorized. It's the perfect way to present a case.
All right, first things first. You can't treat it if you can't define it, right? So let's make sure we have a clear, concise definition locked down.
Okay, so what does this really mean? Well, normally, you've got a tiny bit of fluid in that space. Think about 5 to 15 milliliters, which is basically just a few teaspoons. It's just enough to act like a lubricant so your lungs can glide smoothly. A pleural effusion is what happens when that whole system goes haywire and fluid starts building up, which, as you can imagine, puts the squeeze on the lungs and makes it hard to breathe.
This right here, this is the most important fork in the road for your entire workup. You see fluid on a chest x-ray, and the very first question you're going to get asked is, okay, is it a transudate or an exudate? Your answer is going to dictate everything that happens next.
So, let's break down the why. A transudate is basically a plumbing problem. It's about physics. You've either got too much pressure pushing fluid out of your blood vessels, that's your hydrostatic pressure, or you don't have enough protein, like albumin, to act like a sponge and hold the fluid in, that's your oncotic pressure. On the other hand, an exudate is a biology problem. It's a local issue. The vessels themselves are inflamed and leaky because of something like an infection or cancer, and they're letting all this protein and other cells spill out into that pleural space.
Now, when you're thinking about the causes of a transudate, your brain should immediately go to big systemic pressure problems. The number one cause, and I mean the one you have to know, is heart failure. The others all fit that same pattern, right? Cirrhosis and nephrotic syndrome, they both cause low albumin, which tanks your oncotic pressure, so fluid just weeps out.
Okay, now for exudates. We shift our thinking from the whole body to one specific spot. The classic cause here is an infection right next door, like a pneumonia. We call that a parapneumonic effusion. Malignancy is another huge one, of course, and so are inflammatory issues like lupus or RA. All of these things are causing local inflammation and making those blood vessels leaky.
So, we have our list of suspects, but how do we actually prove what's going on? Well, we have to go in and analyze the fluid itself, and that means it's time to do a thoracentesis.
Doing this safely is absolutely key. You'll have your patient sit up and lean forward on a table. That helps the fluid pool at the bottom. And you always use ultrasound. It's the standard of care for a reason. It seriously reduces the risk of hitting the lung. But the most important piece of anatomy to remember is where to put that needle. You have to go just above the rib.
And here it is, a classic pimp question for you. Why above the rib? Because the neurovascular bundle, that's the nerve, artery, and vein, they all run in a nice little groove along the bottom of every single rib. Going above the rib keeps you in the safe zone and helps you avoid a really nasty bleed.
Okay, you did it. You tapped the fluid, it's off to the lab. Now the results are back, and you've got to figure out what they mean. This is where you put on your detective hat, and your number one tool is Light's criteria. You have to know this cold. No excuses.
The rule is so simple, but it is so important. You are looking for just one of these three things to be positive. If even one of them hits, boom, you've got an exudative effusion. If all three are negative, it's a transudate. So let's walk through them.
First up, the protein ratio. You just take the protein level from your pleural fluid sample and you divide it by the protein level from the patient's blood. If that number is greater than 0.5, that's your first potential positive flag. It's an exudate. Second, the LDH ratio. Remember, LDH, lactate dehydrogenase, is a marker of cell damage or inflammation. So if it's high, something's going on. It's the same exact idea. You take the pleural fluid LDH divided by the serum LDH, and if that ratio is greater than 0.6, that's flag number 2. And for the third one, we're still looking at LDH, but in a slightly different way. This isn't a ratio. You just look at the absolute number for the pleural fluid LDH. If that number is greater than 2/3 of the upper limit of normal for serum LDH at your hospital's lab, that's your third and final flag. Meet any one of these three and case closed. It's an exudate.
Now, let me give you a pro tip. Sometimes Light's criteria can be a little iffy, especially if a patient is on diuretics, for example. So a great backup check is something called the serum pleural albumin gradient, or SPAG. You just subtract the pleural albumin from the serum albumin. If that gap, that gradient, is big, greater than 1.2, it tells you the protein is being held back in the blood, which points you right back to a transudate.
Okay, so you've cracked the case. You know if it's a transudate or an exudate. You've got a really good idea of the cause. So, now what? It's time to make a plan.
The most important thing to remember here is this. You don't really treat the effusion. You treat what's causing it. The fluid is just the symptom. So if the cause is heart failure, the treatment is diuretics. If it's pneumonia, you're giving antibiotics. Simple as that. Of course, you can also do a larger volume thoracentesis just to drain off the fluid and help the patient breathe easier.
Now, malignant effusions, they're a whole different ballgame. They're tough because they almost always come back. So here, you need to be more aggressive. You can do something called pleurodesis, where you actually put an irritant like talc in there to scar the two pleural layers together. No space means no room for fluid. For patients who need palliative care, an indwelling catheter is a great option so they can drain the fluid at home and stay comfortable.
All right, we have covered a ton of ground. Let's boil this all down to the absolute, must-know, can't-forget facts for your exam day. This is your final briefing.
This slide is your cheat sheet. Know the mechanism. Transudate is a pressure problem. Exudate is a leaky pipe problem. Know the number one causes: heart failure for transudate, pneumonia for exudate. When you do the procedure, where do you go? Above the rib. And burn these numbers into your brain. Light's criteria, ratios, protein greater than 0.5, LDH greater than 0.6. And finally, don't forget that malignancy is a special case that needs special treatment.
And we'll end with one last question to really get you thinking. So, your fluid analysis is back. You know it's an exudate, but when you look at the cell count, it's packed with lymphocytes, not the usual neutrophils. What two big diagnoses should immediately pop into your head? The classic answer here is tuberculosis and malignancy. Knowing these little details, that's what takes you from a good answer to a great one. Something to keep in mind.